And so we're going to go back to our last talk of the previous session. Dr. Sengavalu is going to talk about aortic dissection and rupture during TAVR.
Thank you, Dr. Sushil. I think so. The topic is aortic dissection rupture during TAVR. So we look at the incidence of annular rupture. I know it's a very dreaded complication. One needs to be very careful and anticipate such a big complication in order to prevent it. And the incidence of rupture is about 1% of all TAVR procedures. But it's frequently this complication remains undetected. Sometimes a mild one goes unnoticed. The real incidence is maybe sometimes more than what is reported. And we need to have some predictors of this. If you look at the predictors, very severely calcified aorta, aortic annulus, particularly bicuspid valves with eccentric calcium and calcium extending to left ventricular outflow tract. Or again, sizing of the valve is very crucial. I think oversized valve is one of the important predictors. And one needs to analyze. The key is to prevent. So it's very important to analyze the CT very meticulously and to understand the size. So choosing the valve size is very, very important. And to consider when, like the case what we saw now, to do direct implantation rather than to predilate. So to decide when you need predilatation, whether to do aggressive predilatation and avoid post-dilatation. Again, balloon expandable versus self-expandable valve. Again, to decide the risk of annular rupture is much higher with the balloon expandable valves, particularly when they are oversized. And even with self-expanding valves, about pre-dilatation as well as post-dilatation, choosing the appropriate size balloon and not exceeding the diameters. So again, slow deployment and early identification is a key to manage these cases. And we show you some of our, we had one patient out of our 35 cases, we had one case with annular rupture, which I would share with you. And this is a 73-year-old lady who had severe aortic stenosis symptomatic with a moderate LV dysfunction, ejection fraction of 35%, very frail and a thin-built lady with a BMI of 14.4. She had, the STS score was intermediate with a 4.6. And they were keen to have TAVR, so we decided for a TAVR. The CT showed a tricuspid valve and a tricuspid valve with the eccentric calcium. You see the calcium is more towards the right coronary cusp. So can you have the slides? Is it coming?
Your slides. You've lost your slides.
So this was a patient with a huge amount of eccentric calcium. So in such a situation, one needs to be very careful, and the possibility of annular rupture we should predict. And this patient, you could see there is a very eccentric calcium more towards the right coronary cusp. And we decided to use a balloon expandable valve. Though retrospect, maybe you could have considered even a self-expanding valve in this situation. But then she also had a low right coronary height of 9 millimeters, relatively small annulus with a small LV cavity. The annulus area was 330 square millimeters. Again, to decide on the valve size of this SAPIEN 3 was again crucial. I think, can I have the slides? So we decided to whether to use a 20 millimeter valve versus 23. And at that point of time, 20 millimeter was not available in India. So it's presently available. SAPIEN 20 is available. At that moment, we had a 23. So we decided to implant a 23 valve. So we balloon sized it again. We did a balloon dilatation and did an angiogram at that time. And something. So we did this is the aortogram, and once we did a pre-dilatation, during the dilatation, we injected, and this was a 20 millimeter balloon. We removed 22 ml, so we underfilled the 23 millimeter SAPIEN 3 valve to be very sure. So we removed 2 ml, and this was a deployment, very slow deployment. And after the deployment, the hemodynamics were good. As soon as the valve was implanted, then after a few minutes, we noticed, you could see the rupture, and there was a shunt. Patient was relatively stable for some time, actually the shunt was from the aorta into the right ventricle. And hence this was the RCC to RV shunt. Patient was stable. This was the echocardiogram where you can see the shunt from aorta to right ventricle. Patient then was, we waited for some time. The patient was quite relatively stable at that time, and we had to keep her in the ICU in the monitoring. The next day, she started developing some symptoms, so we thought we should interfere in this patient. So we decided to take her, and we could see the defect. There was a huge defect, and so we decided to we closed this shunt. We used an Amplas duct occluder, 1210 occluder, and the shunt, we closed the shunt, but there was some residual shunt that was present. We didn't want there was some paravalvular leak as well, so we didn't want to do anything for that. But patient is now stable and clinically being followed up, though the shunt remains. So this was our only case who had annular rupture, and I would just show two cases. This is courtesy of Dr. Raj Makar. This is a patient with SAPIEN 3 who had 29 millimeter SAPIEN 3 implantation, and following the implantation there was a large pericardial effusion with hypotension. And so if you look at the CT, again there was an eccentric calcium with the area of 541 millimeter square. So this patient underwent coiling. He did a coiling, and following which the rupture was completely closed with coiling. So this is again with 4 coils. So he was able to successfully bail out from this serious complication, and the patient did well. So similar, there's one more case of his, which again this femoral approach was not a good candidate for femoral approach with high calcium. So they went through the subclavian approach and used a 26 millimeter SAPIEN 3 valve, and the valve deployment went well. But then after the valve was deployed, they noticed a huge aortic dissection, type B aortic dissection. And as you could see here, there's a type B aortic dissection. But you can see that there's no dissection in the ascending aorta, and the valve functioning was good. So this patient was managed conservatively, and this patient did well with medical management on follow-up. The valve functioning was good. There was no significant paravalvular leak, and there was some mitral regurgitation which persisted. So to show you these examples, though these complications can happen, one needs to pay attention to how to prevent it, and also have some tips and tricks to learn how to manage these dreadful complications. So all these 3 patients which we showed were managed. Although these patients had a serious complication, they were all managed and were stabilized. So multidisciplinary procedure planning and meticulous CT analysis is very important, and must have a bailout strategy and drills for different scenarios, such as pericardial tamponade or root injury, and easy access to a heart-lung machine with a surgeon and anesthesiologist is critical in such situations. Thank you.
Thank you.
Thank you, Dr. Sangatvellu. Thank you, Ashish sir and Sharma, Dr. Sharma. Now we go on to trials to know session. Who is that knocking on my door? That's to basically discuss some of these important trials which are relevant clinically. This session is planned. I request the chairpersons for this session is Dr. P.K. Dev here, Dr. Manish Bansal, Dr. Sanjay Marotra. Other moderators, Dr. Indra, Dr. Lingaraj, Dr. G. Jana, Shivadatta, Dr. Shivo Banerjee, Dr. Hariom Tyagi. If you are here, please join on the dais. I request Dr. Sharachandra to come on because other panelists are not there. We have interesting trial session discussed on this, and after this we have live cases coming up from KIMS and AIMS where we see some valve cases, and we'll have endovascular session and the dinner symposium. Inaugural function will be after the symposium at 8 p.m. Then we'll have dinner in the same place. Thank you. Over to you, Dr. Sharachandra.
Never met you, I think. Okay. Okay. Yeah, I missed it.
Good afternoon, everyone. So we begin with the first presentation in this very important session, and I invite Dr. Dhal to speak about the BioFlow BioResorb trial. Dr. Dhal.
So in our quest to improve not just the deliverability, but also the quality, the acute performance, and the long-term performance of intracoronary stents, we have moved a long way. And I'm going to discuss today a trial using the ultra-thin sirolimus-eluting bioresorbable polymer with thin everolimus-eluting durable polymer stents, a trial called BioFlow 5. So, as we know that any new metal drug-eluting stent is going to have thin struts, and this came from the ISAR 4, where we realized that the thinner the stent struts, the computational models depicting flow alterations showed improved flow, the morphometric analysis showed less thrombus adherence. So we have moved from what used to be 150 microns to now 60 micron strut thickness. The second thing in which we've moved is how we are going to have the polymer. Is the polymer going to be a biostable polymer, or the polymer is going to be a bioabsorbable polymer? Besides this, we also need to know how well are we going to put the polymer on these struts. Is it going to be a concentric or a conformal distribution of polymer, or is it going to be only an abluminal distribution of polymer, or is it going to be an eccentric distribution of polymer? And this is how we have evolved over a period of time. So this study used Orcyro, which is actually the iteration which came from Prokinetic, which was a stent from Biotronic, which used an ultra-thin strut cobalt chromium alloy stent platform with a passive coating of a ProBio, which encapsulates the stent, which reduces the interaction between the metal stent and the surrounding tissue, and an active component called BioLute, which consists of the most proven limus family, and we know that sirolimus not just is the first drug, but also is one of the most important drugs, and it is available free to all the, because it's off patent, so it is available easily to all the stent manufacturers, along with a bioabsorbable polymer matrix comprising PLLA, which achieves a controlled drug release. And the actual strut size of this stent for 2.25 to 30 millimeter diameter stents was 60 micron, whereas for more than 3 millimeter diameter stents, it is 80 micron. So this is just, the sirolimus is 1.4 microgram per millimeter square, with 80% being eluted in the first 90 days. And a lot of randomized clinical trials were done, which involved the bioabsorbable polymer sirolimus eluting stent, which included the BioFlow 2 study, which was a European study, which was randomized against Xience Prime, and the BioFlow 4 study, which is in Europe and Japan, which is again randomized 2:1 against Xience Prime or Expedition. And then we had a few studies like the BioScience, which was a Swiss study, and a BioResort, which was a Dutch study. And all these studies had consistent clinical outcomes with low event rates, with target lesion failure at 12 months, which was actually not just in the Biotronic initiated or the, but also in the investigator initiated trials, were reasonably consistently good. In fact, definitely not inferior, and sometimes even considered superior to the existing biodurable polymer stents. So the perspective was that the persistence of adverse events with both first generation and contemporary permanent polymer-based DES presents an opportunity for iterative improvement, including thinner stents, stent design modifications, improved geometry, improved polymer biocompatibility, bioabsorbable polymers. And BioFlow 5 actually compared this. It was a prospective multicenter 2:1 randomized controlled investigational device exemption trial. And this had 1,334 patients, which are randomized across 91 centers in US, Canada, Europe, Israel, and Asia Pacific region, where 2:1 randomization of Orsyro versus Zions Prime with clinical follow-up at 1 to 6 months, target lesion failure at 12 months, was defined as the composite of cardiovascular death, target vessel-related myocardial infarction, or ischemia-driven TLR, with a 12-month follow-up and an annual clinical follow-up up to 5 years. Standard patients were included, those who had coronary artery disease, stable or unstable angina, with less than 3 de novo target lesions and less than 2 native target vessels, between 2.25 and 4 millimeters in diameter, with lesion length less than 36 millimeters. TIMI flow, usually more than 1 was acceptable, and these were eligible for dual antiplatelet with definite informed consent. Recent STEMI, or hemodynamically unstable end-STEMI ACS CTO bypass grafts, major side branches more than 2 millimeters were actually excluded. As you can see from the clinical characteristics, they were very well matched, and in terms of age, gender, blood pressure, dyslipidemia, diabetes, prior MI, prior PCI, prior CABG, smoking, and you can see that about 50% of these cases had acute coronary syndromes. Again, if you look at the angiographic or procedural results, about 60% of them had moderate to severe tortuosity, which again looked at the device delivery, as well as being type AHACC B2 or C lesions, which is about 70 to 75%. If you see the procedural outcomes were pretty good in terms of lesion success, which was 99.5% with Orsyro, comparable with Zions. Device success was 97.7%, and procedure success was 94%, which was in fact a little better than Zions. If you look at the primary endpoint of 12-month target lesion failure, the p-value of 0.040, Orsyro performed superior to Zions. And this is important because if we analyze this further, this actually resulted in all 3 categories of cardiac death, target vessel MI, and clinically driven TLR. This endpoint was a 12-month target lesion failure, which can be seen from this landmark analysis. Even at the 30-day analysis, the bioabsorbable polymer sirolimus-eluting stent of Orsyro fared as well, if not better, than the biostable polymer. Again, we can look at the landmark analysis between 30 days and 12 months, and we see that the difference which appeared at 30 days continues to 12 months. There was, despite a comparable 12-month dual antiplatelet adherence, which is about 92% in both, the stent thrombosis rates were lesser in the Orsyro group as compared to the Zions group. The target lesion failure at 12 months, even by subgroup analysis, we can see whether in terms of small vessels, by age, by gender, by presence of diabetes, lesion length, or the presence of ACS favored Orsyro. Further, what they did was that they took the results of the previous 2 studies, the data that they had in BioFlow 2 and BioFlow 4, and from these 2 multi-center regulatory trials, they took out the cases for Bayesian analysis, and they included this, so thus making a total of about 2,200 patients, and they conducted a Bayesian analysis of this. For these patients had to have completed at least 330 days of follow-up, and these were re-adjudicated by BioFlow 5 education committee, including additional events which are not previously adjudicated. And this, if you compare by the Bayesian analysis, again showed that the BioFlow 5 showed that the Orsyro stent, in a pooled Bayesian analysis, performed not just non-inferior, but actually the posterior probability with a post hoc analysis performed superior to the Zions stent. In a multivariate analysis, this was seen to be also extending whether it was done with more than 1 vessel being treated, or regardless of the number of target lesions. And this multivariate variable analysis of target vessel MI also showed that there was a definite significance over the Zions stent. Though the strut thickness in more than 3 millimeter diameter in the Orsiro is 80 microns, but the target lesion failure superiority continued even in these stents which are more than 3 millimeter diameter. So to conclude, it was an internationally randomized trial where the Orsiro was compared to Zions. Differences in MI were observed early but persisted in landmark analysis. There was favorably low TLR in stent thrombosis. There was unequivocal non-inferiority with mean target lesion failure treatment of minus 2.6%, favoring Orsiro, and posterior probability of superiority of about 97%. This was done through statistical Bayesian pooled analysis, taking studies for cases from the BioFlow 2 and 4 study. This was published in Lancet last year. And if we just have a quick review, the importance of fast endothelialization, thinner struts result in faster endothelialization, and it has been confirmed that 65% strut coverage happens at 7 days with Orsiro with reasonably mature neointima and effective endothelialization for better long-term outcomes. So even in the first 48 hours, we can see Orsiro showed better patient outcomes, and this continued up to 1 year. And by OCT data, we know that 65% of struts are covered at 7 days, at 1 month, 92%, 3 months, 97%, and 6 months, 98%. So this is the right quantity and quality of mature endothelialization, and only 4% of uncovered struts were there 3 months, and there was a reduced risk of late thrombotic events. The bioscience is another trial which is actually being done, which is going to look at the STEMI subset, and this is also showing an advantage. And we have some future studies in small vessels, and there is a study for reduced DAPT, and there are some investigator-initiated trials like the Ionic and BioSTEMI, which may actually be looking at superiority. Thank you very much.
Thank you, Dr. Dhal, for this very nice overview of the trial and the science behind this technology. I think we'll move to the next presentation because of the paucity of time. So I invite Dr. Kirtane for his presentation on decision CTO, Euro CTO trials.
Well, thanks so much for having me. I'm just going to present several trials in the CTO space because it's definitely been quite a year in that space for clinical trials, and I think it helps inform all of our practice, not just in CTOs, but outside of CTO as well. The first trial everybody, I think, is familiar with is decision CTO, but there's some nuances to the trial that people are less familiar with. This was a trial that was a multicenter trial in Korea that aimed to establish whether CTO PCI compared to CTO PCI plus PCI of the non-CTO vessels was associated with improvements in outcome. And that issue of multivessel disease is really, really paramount for this particular study because I think it helps to explain some of the outcomes. Originally slated to be a much larger trial, it ultimately enrolled approximately 800 patients. And so what was important to note is, this is from the trial design slides themselves, is that patients presenting with multivessel disease and the CTO in both arms underwent PCI of the non-CTO vessels as part of the randomization strategy, and then the CTO arm had the CTO done in addition to that. So what that essentially caused is a fair amount of noise between the two arms because both arms were having a PCI of some kind, and that happened in a large number of the patients as a whole. The study flow is shown here. In total, approximately 834 patients were enrolled in a 1-to-1 randomization to medical therapy versus PCI, but the medical therapy arm also did have the non-CTO PCI as well as the CTO arm. Initially, the trial, there were design slides that were circulated when the trial was initiated suggesting superiority of the CTO arm versus the non-CTO arm. But subsequently, when the trial was presented, it was presented with a non-inferiority endpoint and a curious one with non-inferiority of medical therapy compared to PCI of the CTO. Generally speaking, when one does a non-inferiority trial, you're trying to compare according to an established standard. And in this case, it's not clear that PCI of the CTO vessel is the standard, so this is somewhat curious in terms of its design. But aside from that, the margin and the other attributes of the study were as would expected. Now, because the study was originally designed to be approximately 1,200 patients and it took time to recruit these patients, the study was terminated early, which also in a non-inferiority design would tend to bias towards the null or no difference between treatment groups. Here are the baseline characteristics, and I think the key things that I'd like to point out are that multivessel disease was present in 73% of the population, and any PCI was done in 50% of the medical therapy group and 90% of the CTO group, suggesting that both groups were having PCI, which could improve their symptoms as a whole. The total number of stents was shown here in the bottom of the slide, 2 in the medical therapy group, 2.4 in the CTO group, with longer stent length noted for the CTO group, as one might expect because the CTO is being treated. Medical therapy in general was reasonable, although not to the level that was seen in COURAGE. And in addition to this, one can see that the primary endpoint, as was presented at the ACC a couple years ago, showed no difference between the two treatment groups. Certainly, there was no superiority of one therapy versus the other over the follow-up period of the composite of death, MI, stroke, or any repeat revascularization. Now, while these trial results were reported as uniformly negative, there are some subtle differences in terms of quality of life scales, and the authors have updated some of these analyses and will be presenting them shortly, if not already at the TCT Asia Pacific meeting, which occurred most recently. Also of note is that there was crossover in both treatment groups. Approximately 20% of patients in the medical therapy group crossed over and had PCI of the CTO, and approximately 15 to 20% in the PCI arm did not undergo successful PCI, further confounding the results. And the authors, to their credit, have published this slide or presented this slide in which the as-treated analysis is shown. And it's interesting that while this does not achieve significance across the board, it is pretty clear to see that among the patients who ultimately ended up with PCI, those were the patients with the lowest rate of adverse outcomes, either initially assigned to that strategy or crossing over from medical therapy in this analysis. So the summary of Decision CTO is that it was presented about a year ago at ACC, and there's no publication yet. We do anticipate seeing these results also with the updated data in terms of quality of life, which the authors have done. Now, a trial that was just published in the past week was EuroCTO, and this is a trial not quite the same size, but originally designed to be the same size, but then did achieve enrollment, and there was also a change in endpoint within this specific trial. This trial was an open-label study of CTO PCI versus medical therapy, and the primary endpoint of the trial was Seattle Angina Questionnaire outcomes. You'll be hearing a lot about the Seattle Angina Questionnaire because this is a sort of validated instrument to assess angina. The most commonly used metric in this questionnaire is anginal frequency, and that's something we'll talk about in a second. There were also safety endpoints assessed in this trial too. As I stated before, the trial was supposed to be 1,200 patients, but unfortunately, due to slow enrollment, only 407 patients were enrolled in the trial, therefore limiting the power to assess complications and or efficacy. Now, one of the things that's unique about this trial, especially in comparison to Decision CTO, is that patients underwent non-CTO PCI up front. These are patients with multivessel disease. They underwent it up front prior to randomization, so as to take that noise out of the primary study comparison of CTO PCI versus medical therapy alone. And that's quite important because that prevents the confounding of the results with patients' quality of life improving in the non-CTO arm. It was a 2-to-1 randomization as shown here, and optimal medical therapy was achieved per standard guideline-based measures, but again, randomization and the baseline Seattle Angina Questionnaire assessments were done 4 weeks after non-CTO PCIs were treated. Patients who had CTO PCI could then potentially, if it failed and medical care indicated that they needed something further, such as a bypass surgery, could undergo that. And similarly, patients with medical therapy who failed medical therapy could undergo CTO PCI, but that only occurred in 7%. So much lower crossover seen in this trial compared to Decision CTO. The techniques were generally contemporary. This is a multicenter study done in Europe with retrograde approach done in 36% of patients and a bilateral approach done in 80% of cases across the board. The length of stents was approximately 66 millimeters, and the number of stents used were 2 across the board. Now, in terms of the primary endpoints, this data was initially presented at EuroPCR, and there have been some corrections to the data. Inadequate statistical testing was done, and so the final version that came out last week in the European Heart Journal is reflected here on this slide. And what this basically showed is that there were improvements in both arms in three of the 5 domains of the Seattle Angina Questionnaire, most notably anginal frequency, and these were differentially better with PCI compared to not PCI of these CTOs. So quality of life improvements in a randomized trial of CTO PCI. Additionally, there were no real adverse events that were seen that favored medical therapy over CTO PCI, so this demonstrates that the therapy could be done safely and effectively in this patient population. If one tries to look at the patients that had the most marked improvements in angina questionnaire metrics, such as exercise frequency or quality of life, anginal frequency, and freedom from angina, this was illustrated nicely in this type of analysis, which is also in the paper, figure 2, and in this analysis there were improvements across the board with CTO PCI compared to medical therapy. Now, those were the 2 randomized trials. I do want to spend a brief second talking about OpenCTO, and the reason I want to mention OpenCTO is because it also centers the side effects and some of these quality of life improvements in a non-randomized fashion, but is important for operators who wish to undertake these vessels. This really sought to look at the best of the best hybrid operators in the United States and Canada, well-versed in CTO PCI. And these are the sites that were involved in the trial, including our center in Columbia. Now, CTO success was challenging. You really needed to know the hybrid approach because the initial strategy chosen was only successful 57% of the time. So if you only know antegrade techniques, you're not going to be successful with these cases up to 90% of the time, which is what was seen in the study. Notably, there were improvements in quality of life across the board within the study, reductions in dyspnea in the study, and that was really seen in patients that both got better with open vessels as well as those that had closed vessels. The key point, though, I wanted to mention with CTO PCI in particular, though, are the complication rates. These are not cases that you should just undertake for the sake of undergoing complete revascularization. These cases have a clinical perforation rate that ranges from up to 5% and a periprocedural MI rate of about 2 to 2.5% with mortality that can approach 1% in hospital. So these are stable patients coming in with a CTO with a mortality rate of 1%, some of which is based upon their baseline demographics, but some of which is important because of the complications that can occur. So if one is not well versed in how to